Hi everyone, my name is Gurjat Basra and I'm the Manager of Patient Programs, Research and Advocacy at Lymphoma Canada. And I'm pleased to welcome everyone to today's session titled Large B-cell lymphoma and other high-grade B-cell lymphomas. We appreciate those who have been able to join us live today to learn more about the disease-specific biology of this lymphoma subtype, as well as novel treatment options available for Canadians. So before I introduce the speaker, I just want to provide some guidance regarding the Zoom software for this session. So this virtual software does not allow you to share your video or turn on your microphone. Hence, if you do have any questions, please save it for the aggressive B-cell lymphoma Q&A session after this presentation. So without further ado, to introduce our speaker, today we have here Dr. Robert Puckrin, who is a hematologist and staff physician in the Alberta Blood and Marrow Transplant Program at the University of Calgary, with interest in lymphoma, CAR T-cell therapy, stem cell transplantation, and clinical research. So thank you so much for joining us today, Dr. Robert Puckrin, and I'll hand it over to you.
Great, thank you very much for the kind introduction, and hello to everybody who's joining us today. Thank you for being here. It's my pleasure to be here to chat about one of the lymphomas that we commonly treat in hematology called diffuse large B-cell lymphoma. Of the many different types of non-Hodgkin lymphoma, this is one of the most common. It represents about 30% of all different types of non-Hodgkin lymphoma. And we consider lymphomas to behave in different ways. Some are what we call indolent, meaning they grow very slowly over a period of many years. Some are more aggressive, and that means they tend to grow more quickly over a period of a few weeks to months. And diffuse large B-cell lymphoma tends to be one of the more rapidly growing cancers that can make people sick quite quickly, but fortunately, they're also often treatable and often curable as well. You may wonder where this long, confusing name of diffuse large B-cell lymphoma comes from, and it actually relates to how the lymphoma looks under the microscope. So on the bottom here, I have a couple of pictures of a lymph node, which is affected by this lymphoma. And on the left, you can see that most of the lymph node has actually been replaced by the cancerous cells. So it has kind of a diffuse or a widespread pattern in the lymph node. And then on the right, you can see closer up that these cancerous cells are quite large in size, and they're made up of malignant or cancerous B cells. So that's where the name diffuse large B-cell lymphoma comes from. For short, though, we call it DLBCL. So this is, as I mentioned, a fairly common lymphoma. It's diagnosed in more than 1,000 to 2,000 Canadians every year. Probably the most important risk factor is age, and the average age at diagnosis is about 65 years. It does occur slightly more common in men than in women. It's also a bit more common in Caucasians. But other than that, we don't fully understand what causes this lymphoma. I often tell my patients there's nothing that they did that caused this disease to occur. There's nothing they could have done to have prevented it. It's just that as we grow older, these random mutations can occur in our lymph nodes. And our lymph nodes, which are normally a healthy part of our immune system, can then become cancerous and start to grow out of control. There are some other risk factors, for example, certain infections like HIV, or sometimes being immune suppressed because of certain medications for an autoimmune disease, or sometimes for an organ transplantation that can increase the risk of this lymphoma. But in general, it's not an inherited disease. This is not a lymphoma that's directly transmitted from parents to children, for example. So how does this lymphoma actually come to attention? Most of the time, a person will actually notice an enlarged lymph node. So that can be a lump that starts to grow over a period of a few weeks in the neck, or sometimes under the arm, sometimes in the groin as well. Sometimes the lymphoma can release a lot of inflammation into the bloodstream, and that can cause what we call B symptoms. So that can lead to quite significant fatigue and sometimes fevers, drenching sweats where you wake up covered in sweat at nighttime, and sometimes it can cause weight loss as well. And although lymphoma usually affects the lymph nodes, sometimes it can also spread to other organs in the body. So commonly that might be the bone or the bowels, and rarely this lymphoma can also affect the brain. So how do we diagnose this disease? So the most important step is to have a biopsy, and that's usually a biopsy of an enlarged lymph node. There are different ways to go about doing that, but usually we give some local anesthetic freezing, and then there's often a small needle that's inserted to collect a sample of the lymph node. Sometimes we actually do a minor surgery to remove the entire lymph node. And sometimes we have to use a CT scan or an ultrasound to biopsy a different organ if the lymph nodes are a bit harder to reach. The biopsy is then reviewed by a pathologist who will look at it under the microscope and do additional testing to confirm the diagnosis. The other most important test is an imaging test called a PET scan or a CT scan, and that's done to help stage the lymphoma. That means we want to find out exactly where it is in the body. So here you see a picture of a PET scan where a special contrast or a dye is injected into the person, and if there's any lymphoma in the body, it will take up that dye and light up very brightly on the PET scan. So it's a very good tool that helps us to determine exactly where the lymphoma might be active. We also do a series of other tests when a person is diagnosed with this lymphoma. So we always do a measurement of blood counts. Sometimes the lymphoma can affect the bone marrow, which is kind of the factory of our blood. And if there is lymphoma in the bone marrow, that can cause the blood counts to be low. It's also important to measure how well the organs are working. So we measure a test called creatinine, which helps to see how well the kidneys are working. And we can also measure blood tests that see how well the liver is working. And that's important, especially when we're using chemotherapy, because we need the organs to be strong enough to be able to go through that treatment. We also have a tumor marker called LDH. It's not a perfect tumor marker because it can go up and down for many different reasons, but sometimes, especially in aggressive lymphomas, the LDH can be quite elevated, and that's something that we can monitor during treatment. Oftentimes before starting chemotherapy, we'll do an assessment of how well the heart function is working. So that's an echocardiogram. It's basically an ultrasound of the heart, just to make sure that the heart is strong enough to go through the chemotherapy. And then we also do screening tests for certain infections. So I mentioned that HIV can predispose to this lymphoma, so we often test that just as a screening. And then certain viruses like hepatitis B or even hepatitis C can also reactivate if a person is undergoing chemotherapy. So we often will screen for those viruses and sometimes other infections like tuberculosis if there are any risk factors or exposures in the past, so that we can appropriately treat those infections and prevent them from becoming a problem during chemotherapy. In the past, we probably did a lot more bone marrow biopsies than we do nowadays. And that's a test where we take a small sample of the bone marrow from the lower back or the pelvis. But nowadays, with better imaging tests, especially PET scans, we oftentimes don't need to do a bone marrow biopsy routinely. It can still be helpful in some cases, but oftentimes if we have a PET scan performed, then we don't have to do the extra test involving the bone marrow biopsy. So how do we stage diffuse large B-cell lymphoma? Well, it's very similar to other types of lymphoma. So stage 1 means that there's a single enlarged lymph node. Stage 2 means that there are 2 or more enlarged lymph nodes, but they're all located in one area, in the upper body, so in the neck or the chest, or in the lower body, like in the abdomen. Stage 3 means that there are multiple lymph nodes that are affected on both sides of the body, so both the neck or the chest and the abdomen. And then stage 4 means that the lymphoma is not just affecting the lymph nodes, but it's also affecting other organs like the bone marrow or the liver or the bowel. But I often tell my patients that staging is important in DLBCL because it does help to guide prognosis and it helps to guide our treatment a little bit as well. But what's important to remember is that regardless of the stage, DLBCL is often a curable and still highly treatable disease. So even if the cancer is stage 4, we often still have very effective treatment for it. So the most common treatment for diffuse large B-cell lymphoma is a combination of chemotherapy and immune therapy. And that's a regimen that we call R-CHOP, and we've been using this for the last 20 years or so. It's a combination of 5 different drugs. So the first is rituximab, which is an exciting immune therapy. It's actually an antibody that's targeted to the lymphoma. So it helps the immune system to get rid of the cancer and to attack it. The next 3 drugs, cyclophosphamide, doxorubicin, and vincristine, are chemotherapy drugs. So they help to target the more rapidly growing cells, including the cancer cells. And then prednisone is a steroid. It's a strong anti-inflammatory that's also quite effective at treating lymphoma. So most of these treatments are given intravenously, all on one day. The prednisone is taken as tablets by mouth for 5 days, but this treatment is repeated every 3 weeks for usually about 6 cycles. So in total, it's about 5 months of treatment. Most of it is outpatient. That means a person is at home for most of the 5 months of the treatment, but every 3 weeks they do come into the cancer center to receive the 1 day of the intravenous chemotherapy treatments. Now, R-CHOP does have side effects, and there are lots of ways that we help to prevent and monitor and reduce the severity of these side effects. The fairly common ones that we encounter might be low blood counts. So the chemotherapy can suppress the bone marrow and can cause some temporary anemia or low red blood cells, or sometimes low platelets, which usually recover once the chemotherapy is completed. But the most important one is that the chemotherapy can cause low white blood cells. So if the white blood cells go low, the immune system may then not be strong enough to fight off infection, and people can be at risk of developing fevers and infections. So the most important thing to remember is if a person develops a fever, so a temperature more than 38 degrees, at any point during those 5 months of chemotherapy, it's very important to call in immediately to your doctor or clinic so that you can be tested and oftentimes even admitted to hospital for intravenous antibiotics to help treat an infection while the white blood cells are too low to fight off an infection. Other than infections, common side effects include fatigue, and that can take several weeks to months to slowly recover. Chemotherapy can also cause nausea, but we have lots of very good anti-nauseants nowadays, so we're usually quite effective at preventing nausea. Hair loss is common, as with many other chemotherapies, but fortunately it does tend to come back in most cases. And then the chemotherapy can also cause some mild damage to the nerves called neuropathy. So that usually can present with some numbness or tingling in the fingers or toes. We monitor for that. If it becomes more severe, then we can often reduce the dose, and that usually helps. And then usually the neuropathy and the nerve function does improve and recover over time once the treatment is completed. And then sometimes we can also see infusion reactions, which is kind of like an allergic reaction, especially the first time we give the chemotherapy. And we oftentimes give what are called pre-medications like Tylenol or Benadryl to help prevent those reactions from happening. So those are the fairly common side effects. They're usually manageable and reversible. There are some potentially more serious side effects that can also happen, but fortunately they're more rare. So sometimes the chemotherapy can cause what's called tumor lysis, which is when the lymphoma cells very quickly die off after treatment, and they can release a lot of electrolytes into the bloodstream that can sometimes be damaging to the kidneys or to the heart. So we do monitor for that, and if a person is at higher risk, we do have medicines that can help prevent that from happening. Rarely a very severe infection can occur from chemotherapy, and rarely one of the chemotherapy drugs can also affect the heart function and cause the heart to not pump blood as well as it did before. But to help protect against that, we do always screen for the heart function before starting treatment to make sure it is strong enough to go through the chemotherapy. Usually R-CHOP doesn't cause infertility, but there is a risk that that could occur. So for a person who has the potential to have children and wishes to protect the fertility, there are options that we can do before starting chemotherapy to help collect and preserve fertility for afterwards. And then finally, anytime we use any chemotherapy, there's a very small risk of a secondary cancer, like a leukemia, that can sometimes occur years down the road, sometimes due to the genetic changes that chemotherapy can cause in the bone marrow. Those can be hard to treat, but they are fortunately rare. And in general, despite these potentially severe side effects, the benefits of the chemotherapy and their effectiveness at curing this lymphoma do greatly outweigh any potential risks. And we always do carefully monitor and do everything we can to help prevent these complications from occurring. So what can you do as a patient to help make R-CHOP chemotherapy easier? So the most important thing is to see your doctor and nurse team regularly and to follow the medications that they've prescribed for you. Like I said, we have lots of very good anti-nauseants to help keep symptoms at a minimum. We often use a medicine called GCSF, which is a hormone that helps to stimulate the bone marrow and make more white blood cells. And that can help to reduce the risk of fevers or infections. We sometimes also use preventative antibiotics or antivirals to help prevent infections. And there's some new research coming out recently that cholesterol-lowering medicine like a statin can also help protect the heart function during chemotherapy. So many of us have started to use that, especially in patients who might be at higher risk of having a heart complication from the chemotherapy. Throughout the months of treatment, it's important to monitor your symptoms and report them to your medical team, especially things like fevers or infections. You have to report those quickly so they can be treated properly. And in general, I always advise my patients just to take care of themselves. Having this diagnosis and undergoing treatment is hard. It's important to make sure that you're having a healthy, well-balanced diet. There's no particular diet that I recommend following or particular restrictions to consider. It's really just making sure that you're eating healthy, well-balanced meals to keep your body strong and healthy. Gentle exercise like walking, getting some fresh air, it's a very good idea to help boost your physical strength and your mental strength during chemotherapy. And getting a good night's sleep as much as possible is also really important. It's important to remember that going through cancer treatment can be very stressful and can cause a lot of anxiety. And there are supports out there to help make it easier. So chatting with friends and family is really important. And many cancer centers will have a team of psychologists or counselors, social workers who are available for support. So don't be shy to ask. There's always a great team available to help and support you. And then in general, we recommend avoiding things that might make you sick during chemotherapy. So avoiding things like smoking or excess alcohol use, and trying to avoid people who might be sick or have a cold. Just because the chemotherapy is immunosuppressive, we don't want you to get an extra infection or illness on top of it. Now, there are some other treatments that we also sometimes use to treat this lymphoma. So in some cases, we give radiation therapy after the chemo, and that might be done if there's still a little bit of leftover lymphoma at the end of treatment, or if the lymphoma was just in one particular site to begin with. There are also certain subtypes of diffuse large B-cell lymphoma that don't respond as well to the standard R-CHOP chemotherapy. So sometimes we use stronger or more aggressive chemotherapy in those cases. So there's one other chemotherapy protocol called EPOCH-R, which is similar to R-CHOP, but it's a bit stronger. And we sometimes use that in cases that don't respond as well to R-CHOP. And then sometimes lymphoma can present in special places like the brain, for example, which has a protective lining that prevents most chemotherapies from getting in and effectively treating lymphoma in the brain. So in those cases, we have to use specially designed chemotherapy, which are quite good at getting into the brain. And we also often use stronger treatments, including a stem cell transplant, which I'll discuss afterwards, to help treat lymphoma in those spots. So what's the prognosis of diffuse large B-cell lymphoma? Well, because it is an aggressive disease, it often is fatal if left untreated. But the good news is, with treatment and R-CHOP, the majority of patients who have this lymphoma will be cured. So on average, we're able to cure about 2/3 of patients who receive the R-CHOP treatment. And cure means that we put the cancer into remission, and it's gone away and never comes back, and that person goes on to live a long, happy, healthy life, as we hope. The chance of cure, though, can depend on a number of different individual factors. So in general, it can depend on things like a person's age, as well as their general health condition. And then there are also individual risk factors that your oncologist will look at. There's an International Prognostic Index score, and it's a series of risk factors that includes things like blood work changes, as well as stage and exactly where the lymphoma is. And that gives a total score of 0 to 5 that can help predict the success rate of R-CHOP. On the actual biopsy of the lymphoma, we also oftentimes do specific genetic tests, looking at things like the cell of origin of the lymphoma, or for specific mutations involving genes like MYC or BCL2. And these can also help us predict how well the R-CHOP is likely to work. And then the other most important factor is that we'll monitor the response to treatment. We'll oftentimes do a repeat scan partway through treatment, and another one at the end to get a better sense of how well the chemotherapy is working. So your oncologist will often look at a combination of these factors to determine an individual prognosis, and that will help predict for each person how likely the R-CHOP is to work as we hope. So what happens once the chemotherapy is completed? So after the usually 6 rounds of treatment, we'll typically repeat a PET scan, perhaps a month or 2 afterwards. And our goal is we're not going to see any lymphoma lighting up on the PET scan. And we consider that to be a remission where the lymphoma is no longer active. After that, we typically don't do any more treatment routinely, and it's really just monitoring and surveillance. So oftentimes we'll check in and see how our patients are doing every 3 to 4 months for the next year or 2, and then less often as time goes by. The most important things that we check for would be for symptoms like new or enlarging lymph nodes, or sometimes new fevers or night sweats. And we also monitor the blood work. And these are often quite helpful to assess if the cancer may or may not be coming back. We don't usually have to do regular imaging if a person is feeling well, because most studies have shown that doing regular scans aren't particularly helpful. But for the most part, we monitor a patient's symptoms and the physical assessment as well as the blood work changes. It is possible, despite the high cure rates, for this lymphoma to come back. So that can occur in up to 30 to 40% of patients, and we call that a relapse. If the lymphoma does recur, it usually happens within the first 1 to 2 years. It's much less common for this lymphoma to come back after that point. The bad news is that if the lymphoma does come back despite the R-CHOP, it can be more difficult to treat. It does require stronger therapies. The good news is these therapies are also quite effective, and we actually still have at least 1, 2, and maybe 3 new treatments that can cure the lymphoma, even if it comes back after R-CHOP. So just to give a quick overview of what these treatments might look like. So the first that we've been using for a good 20 to 30 years is called an autologous stem cell transplant. So this is a treatment that involves, first of all, giving some chemotherapy to help shrink the lymphoma back down and help the person feel better. We tend not to use R-CHOP again if it didn't work as so well the first time. We tend to use different and oftentimes stronger chemotherapies. After that, if we've achieved our goal of shrinking down the lymphoma, then we'll collect stem cells. So stem cells are like the mother of our blood. They live and grow in the bone marrow, and they divide and make all the blood that flows through our body. But to move the stem cells from the bone marrow into the bloodstream where we can more easily collect them, we oftentimes give some chemotherapy along with G-CSF, which is that medicine that helps to stimulate the bone marrow. And then after that, we can collect the stem cells straight from the bloodstream using a machine called apheresis that you can see at the top here. So this is a machine that filters the blood, and it helps in that it can remove the stem cells from the blood. And we put those stem cells into a special bag, which then can be frozen and stored and used in the future. And the rest of the blood is returned to the patient. After that, the patient is usually admitted to the hospital for the final treatment, which is the actual stem cell transplant. So this first involves receiving very high dose chemotherapy, which is much higher than any chemotherapy that we usually use. And it's really designed to help kill off and wipe out any lymphoma that might remain in the body to really maximize our chance of curing the disease. As a side effect, though, the high dose chemotherapy can also wipe out the patient's own bone marrow and make it impossible for them to make blood again. So to rescue them from that, after the chemotherapy is finished, we take the stem cells out of the freezer, we thaw them, and then we infuse them back into the patient, right through a central line that can be kept for a few weeks, like a blood transfusion. And those stem cells will then travel to the bone marrow, and after a couple of weeks, they'll start to grow and divide and make new blood for the patient again. So this is quite a strong treatment. It oftentimes involves being in hospital for a couple of weeks. During that 2-week period after the high dose chemotherapy, that's when most of the more serious side effects can occur. So the blood counts will usually be low for a couple of weeks until the stem cells start to kick in and make new blood. Most patients will require a blood transfusion. They may get fevers and infections and require some antibiotics. And then the chemotherapy can be quite hard on the rest of the body as well, and it can cause nausea and diarrhea and house sores. So there may be a few days in there where most patients aren't feeling very well, not wanting to eat a whole lot, but it's important to remember they'll be well taken care of by a great team of experienced doctors and nurses, and we do have lots of different medications and nutritional support and things we can do to help make these symptoms more manageable. The most important thing to remember is, as bad as the symptoms are, they're temporary. So usually by the 2-week mark, once the stem cells take and start to make new blood again, the body starts to heal up very quickly, and people tend to feel better quickly as well. There is a small risk that something more serious could go wrong during this treatment as well. That can sometimes be a severe infection. Sometimes an organ can be injured, and rarely there can be even a fatal complication that can occur from this treatment. But to help minimize the risks of those more serious complications, we do a series of tests beforehand to make sure the body is strong enough to go through the treatment. There are also some long-term side effects from the stem cell transplant to be aware of. So energy can be quite low afterwards. It can take several months to recover. The appetite can also be low, and the taste buds also take a few weeks to improve after treatment. And then there's also a higher risk of infection because it's basically like a new immune system. So we often give our patients preventative antibiotics, and we also oftentimes redo vaccinations to help retrain the immune system afterwards. The chemotherapy can also cause infertility, so it's important to talk about that with your doctor beforehand so that we can preserve and protect fertility. There's also a small risk of secondary cancers, as with any chemotherapy, or other organ complications, which we closely monitor for. Now, one of the other new treatments that's shown a lot of promise for diffuse large B-cell is CAR T-cell therapy. So this treatment really uses the immune system to help get rid of the cancer. So it's a very promising new approach that can work even when standard chemotherapy or stem cell transplants haven't been effective. So with CAR T-cell therapy, we first collect a patient's T cells, and you can see what a T cell looks like right here. It's really a type of white blood cell that helps to fight off infections, but it also helps our bodies fight off cancer. The problem is cancers have ways of getting away from our immune system. So to help sort of retrain and boost our immune system, we can collect a patient's T cells, and then we genetically engineer them to express a special receptor called a CAR. And so you can see here a CAR T cell is sort of modified to have all of these receptors on it. And these receptors help the T cell be more targeted. So it's really trained to recognize the lymphoma. And it also helps the T cell to become activated and grow and be very strong at getting rid of the cancer. So this treatment is also typically given in hospital. It does involve a 2 or 3 week stay in the hospital. At the beginning, we often give a few days of chemotherapy, which is just a low dose of chemo designed to help the body accept the CAR T cells. And then we give the CAR T cells back to the patient, just like a blood transfusion. And then they start going to work attacking the lymphoma. And when they start to attack the lymphoma, they can release a lot of inflammation into the bloodstream. And that's one of the most common side effects of CAR T cell therapy, which is called cytokine release syndrome, or CRS. So most often, this feels like a bit of a bad flu. You might feel fever and fatigue and achiness and sore, and that can go on for a few days. In some cases, it can also become more severe and cause the blood pressure to go down, or it can affect the oxygen levels, and it can also sometimes affect the brain and cause what we call neurotoxicity. So that can often be something mild, like a bit of drowsiness or confusion or tremor or trouble finding words. But in some cases, it can be more severe and rarely even cause things like seizures or swelling of the brain. So to protect you from those side effects, we will monitor patients very closely in hospital. And there are lots of very effective medications that we can use to help prevent these side effects from getting too severe. So usually by using strong anti-inflammatory medicines, we can help get the inflammation under control before it gets to a more severe stage. This treatment can also cause low blood counts and increase the risk of infections. And that risk of infections can actually persist for many months afterwards because the CAR T cells can live inside the body. And they don't just attack the lymphoma cells, they also do suppress our healthy B cells, which are important for making antibodies. So it's important to, again, take preventative antibiotics or antivirals and to talk about revaccinations with your doctor afterwards to help protect you from that risk of infection. And then another new immune treatment that we're very excited about is a treatment called bispecific antibodies. So this is a bit similar to CAR T cell treatment, but it really involves an injection of a drug called the bispecific antibody, and it has two arms. With one arm, you can see that it recognizes and binds to a cancer cell or a tumor cell on the bottom. And then with the other arm, it binds to a patient's own T cell, which is the same white blood cell that we use for CAR T cell therapy. So it really is a drug that helps to bring a T cell in close contact with a tumor cell. So it helps the body's own immune system come close and recognize and attack the cancer. And this treatment has proven to be very effective, even in cases where other treatments haven't worked. It's also a lot easier to organize and administer compared to CAR T cell treatment, and also has fewer side effects, although it can also cause the cytokine release syndrome that we see with CAR T cell therapy. It tends to be less severe though. So the first bispecific antibody was recently approved in Canada, and it's currently undergoing evaluation and hopefully will be funded and available in the next year or two. Now, we have to keep in mind that a lot of these treatments, like the stem cell transplant and even CAR T cell therapy, are quite strong treatments, and they do have potentially serious side effects. So they may not be appropriate for every patient with a relapse of diffuse large B-cell lymphoma. If a person is maybe of older age or perhaps a bit frailer, or they have other medical problems, they may not be eligible for those more strong treatments. But the good news is we also do have other treatments that can also help to control the disease in those situations. So sometimes a doctor may consider corticosteroids like prednisone, which is a strong anti-inflammatory that can also help to shrink down or control the lymphoma. Radiation treatment can also be quite helpful, especially if the lymphoma has come back in just one spot. It's a localized treatment that is very effective. And then we also have other more gentle chemotherapy regimens. Some are called GemOx or Pep-C, and they tend to have fewer side effects, but can also be helpful at controlling the lymphoma for some time. And then more recently, we had a few new targeted treatments that have come out for this disease. So in some parts of Canada, we have a regimen called polatuzumab, and that is shown up here. It's an antibody that's really targeted to the lymphoma, and it's attached to a little bit of chemotherapy. So it's a way of delivering chemo directly to the lymphoma. And that's given in combination with the more gentle chemotherapy drug called bendamustine. That can be quite helpful, especially in older patients or those who might have other medical conditions, because it's effective but doesn't cause as severe side effects as other treatments. And then in some parts of Canada, like in Quebec, there's access to another drug called tafasitamab, which you see here. And this is another antibody that's really targeted to the lymphoma. And it's given in combination with lenalidomide, and it can also be quite helpful in these circumstances. So to wrap up, diffuse large B-cell lymphoma is one of the most common and aggressive lymphomas. It can grow quite quickly, and without treatment, it can be fatal. But the great news is that R-CHOP chemotherapy is able to cure the majority of cases. In the small percentage of patients where the cancer does come back, the treatment often is more difficult. But the good news is there are still effective treatments like stem cell transplantation, CAR T cell therapy, and most recently bispecific antibodies, which are very effective and can oftentimes still cure the disease. And what's even more exciting is that there are lots of other promising new treatments on the horizon. So the future is certainly bright for this particular type of lymphoma. And I always tell my patients that I'm optimistic that things are going to go well, that we'll be there to support them through the entire treatment process and have lots of promising treatments available to offer them. So thank you very much for your interest and attention. I'd be happy to take any questions.
Thank you, Dr. Puckgren, for that wonderful presentation. We appreciate your thorough review regarding disease biology, diagnosis, prognosis, and treatment options for Canadians. So now I'd like to direct the audience to attend the aggressive B-cell lymphoma Q&A session after this presentation. So have your questions answered live. Thank you, everyone.